So I'm going to give the beginner's session now for those of you who are new to the WM community or perhaps need some revision before we hear some of the talks. And for those of you who know it all before, now's your chance to get your cup of tea or coffee. So my name is Dima El-Sharkawi and I'm a haematology doctor at the Royal Marsden Hospital. So this is the tree of life for hematologists. This is our bread and butter. This is what we love talking about. So you produce all your blood cells in the middle of your big bone, so your bone marrow. And you have got stem cells that have the ability to replicate, to keep dividing, or become one of your blood cells. And they either divide and become one of your myeloid cells or one of your lymphoid cells. And the cells that go down the myeloid route eventually become your red blood cells, which are the cells that carry oxygen around the body, your platelets, which are the little fragments of cells that help your blood clot, or some of the white cells, and your white blood cells are the ones that fight infection. So the ones that are from the myeloid cells become your neutrophils, and some others that you sometimes see on your full blood count, like the eosinophils, basophils, monocytes. Down the lymphoid route, we have got lymphocytes, and your lymphocytes can either become B lymphocytes or T lymphocytes, and some of your B lymphocytes become plasma cells. Again, these are the more technical white cells that are more specific for fighting different infections, and they fight infections in slightly different ways. But your B lymphocytes, some of them will start producing antibodies, and that's some of the ways that they fight infections. So that is kind of your blood cells in a nutshell. And I thought before I go into a bit more about WM, it's worth just going over some of the definitions and words that we sometimes use interchangeably, just so that we're all on the same page and that we understand everything. So as Charles said, cancer, WM is a form of cancer, but what that actually means is that this is just an overproduction of cells that continue to grow and divide and have escaped the normal controls that our body has that keeps them in check. The only way to diagnose a cancer is by performing a biopsy to see those abnormal cells. So you might suspect someone has a cancer from looking at their scan or their blood test, but the only way to absolutely diagnose a cancer is by biopsy. So that's what a cancer is. So obviously there's lots of different types of cancer because different cells can become cancerous and keep continuing to grow. So lymphoma is a cancer of your lymphoid cells, hence the name. So your lymphocytes can be a lymphoma. So like you can have B lymphocytes and T lymphocytes, you can have B-cell lymphomas and T-cell lymphomas. So as I think most of you know, WM is a form of lymphoma. It's a lymphoma affecting your B lymphocytes that are starting to mature into plasma cells as well. When you have the biopsy, and for most of you that would have been from the bone marrow, what the lymphoma or the abnormal cells that would have been seen by the pathologists is called lymphoplasmacytic lymphoma. So some of you, when you were diagnosed, may have not heard the term Waldenstroms. You may have been given the diagnosis of lymphoplasmacytic lymphoma. And so that's the actual abnormal cells that we see in WM. As I said, most of it may have been from bone marrow, but some of you may have had a diagnosis from a lymph node. So WM is the lymphoma part, so those abnormal cells, plus the presence of the IgM paraprotein, which is the abnormal antibody that these lymphoma cells are producing. So I think it's really just good to kind of get these definitions straight in your mind. So coming back to our tree of life, therefore, Waldenstrom's or WM is the cancer of these B lymphocytes and plasma cells. There are other lymphomas also, but that's what the cells that are affected in WM. And as I said, WM is a combination of the abnormal cells plus the IgM paraprotein that we can detect in your blood by a blood test called protein electrophoresis, looking for this abnormal antibody. So some of you may have first of all had the blood test, so the protein electrophoresis, which detected this paraprotein. And that can lead to the suspicion, we might suspect if we see an IgM paraprotein that someone has WM, but in itself is not diagnostic because then we have to look for the abnormal cells, as I've said. So that's a bit about the diagnosis. So how might it present? So when we talk about presentation, we're really talking about the symptoms. So what you feel when the disease first starts occurring, that might lead us to do all the tests to lead to the diagnosis. So as I said, you've got abnormal lymphoma cells that start crowding out the bone marrow. So your bone marrow starts producing more of these abnormal cells. So the logical thing is it starts not producing enough of your normal cells. So when you develop more and more of the lymphoma cells in your bone marrow, you might become anemic. And how that might present. So what you might feel when you become anemic is shortness of breath, particularly when you're doing things. I find patients first notice it going upstairs or hills. That's when they first realize the problems, and tiredness and fatigue that I think will be a common symptom to most of you. For some people, they may develop low platelets, and that might present with bleeding or bruising. And similarly then, if you've got low normal immune cells, you might have an increased risk of infections. So that's the symptoms if it's affecting the bone marrow. But for some of you, the disease mainly presents in lymph nodes. And so some people might present with an enlarged lymph node gland, either visible or noticed on a scan that you're having for a different reason. So that's from the nodal point of view. So we've got marrow symptoms, we've got symptoms that affect your lymph nodes, and then people can get what we call generalized symptoms. Just as the burden of disease increases, then people might develop fatigue, so tiredness, fatigue, and what we sometimes refer to in the clinical world as B symptoms. And B symptoms are either weight loss, or significant weight loss, or night sweats. Yes, the lymph nodes can be formally assessed by scans. So that's the symptoms from the abnormal cells, so the lymphoma cells that are in the body. But also some people may present with the symptoms not just from the lymphoma cells, but from the paraprotein, so the abnormal antibody that's being produced by Waldenstrom's, which makes it, from an academic or hematology point of view, quite an interesting disease and different perhaps to some of the other lymphomas that I treat. That is not just the symptoms of the lymphoma that you might experience, but also the paraprotein. So I kind of think about the symptoms from the paraprotein in two separate sections. So there'll be some people when they first present who the paraprotein level is very high, which essentially causes what we often refer to as thicker blood. And so that might lead to affecting the small blood vessels in your body, such as kind of in the nose. So people can present with nosebleeds, changes in eyesight because of the small vessels at the back of the eye, headaches, or potentially other problems in the body. So that's when the level of the paraprotein is too high. But then there are some people, and this is where it gets very variable, and not all patients will get potentially any of these complications, but for some it may be the main problem for them, that their paraprotein that is unique to their WM may lead to certain problems. So for some of you, you may have neuropathy that's being mediated by the paraprotein, or other rare things, some of which you'll hear about later today, like amyloid, where the paraprotein or part of the paraprotein is misshapen and folds in an abnormal way, and then that can lead to blockages in different organ or build up in different organs as well. But as I say, that's something that's kind of unique to different patients, and not all patients with WM will get these complications. So you can get the symptoms from the lymphoma or the paraprotein. So that's a bit of background then on diagnosis and the symptoms. But for us as clinicians to make the diagnosis, as I said, it's a cancer, so the only way to make the diagnosis is by biopsy. And the biopsy, first of all, identifies that there's a lymphoma there, that there's an increase in the B lymphocytes, and that they all look the same, that they're clonal. But we're up to over 30 different types of lymphoma. So seeing that there's a lymphoma or not is not enough for us to be able to diagnose lymphoplasmacytic lymphoma and then Waldenstrom. So we will want to differentiate the low-grade lymphomas, so the ones that we think of as more slower growing and indolent, and WM is a form of what we consider a low-grade lymphoma. And sorry, I've used an acronym there. The NHL stands for non-Hodgkin lymphoma. So we want to differentiate that from some of the more aggressive high-grade lymphomas that we treat, and we look at the cells to see whether they look smaller or more aggressive and more rapidly dividing. But then within the low-grade lymphomas, there's lots of different subtypes of low-grade lymphoma. And for some of you, you may have been told that your biopsy, that we can't really tell the difference between whether it's Waldenstrom's or other low-grade lymphomas, such as marginal zone lymphoma. So it is important, and certainly in the UK, this is what happens, that all samples where we suspect a blood cancer, so a hematological malignancy, get reviewed by a pathologist who is specialized at looking at blood cancers. Because, you know, before I came into hematology, I thought it would be easy to diagnose a cancer. It's either you see an abnormal cell or you don't. But actually differentiating between all these different types of lymphoma is an art rather than an exact objective science. So you do need a specialist pathologist reviewing these marrows. And the way that the diagnostic structure is set up in the UK is that all blood cancers are diagnosed by specialist hematopathologists. So that's the biopsy when we're looking at the cells, but now our diagnostics have become much more sophisticated, but also widely available in the UK. So NHS England have invested a lot in allowing for genetic tests to be widely available. So when we make the diagnosis of lymphoma, not only do we don't just stop there, we've started routinely now looking for extra information. So again, to give you a bit of biology background, you've got on the left here, the WM that's in the bone marrow. So these are the abnormal cells that all look very similar. But within the cells, each cell has a nucleus, and that's kind of the brain of the cell. And the building structure that tells the cell what to do is all in the DNA that's arranged in chromosomes. And then within the DNA, you've got genes that basically produce different proteins that tell the cell what to do. So we can look for mutations in the different genes, and this should be standardly done on all diagnostic samples now in the UK at least. And often different centers do things slightly differently, but certainly in our center, we will look for a panel of genes that we know may be mutated to help us try and work out what the diagnosis is. So some of you may be aware of some of these genes. You may know whether they're mutated or not in your case, but these are some of the ones that we know can sometimes have essentially what we call a mistake in the gene. So MYD88, CXCR4, ARID1A, and TP53. So lots of names, but these are things that are, I think, going to become increasingly commonly checked for in patients with WM. So why do we check for these mutations in these genes or these mistakes in these genes? Well, potentially they may help us make the diagnosis. So we know that actually the vast majority of people with WM will have a mutation in the gene MYD88. So around 80 to 90% of WM will have a mutation in this MYD88. So, you know, I told you that we sometimes need to try and differentiate Waldenstrom's from other low-grade lymphomas. Seeing this mutation helps us differentiate. And if we see it it points us more perhaps towards Waldenstrom's. At the moment, the rest of these things are really the subject of research. So we look to see whether having the mutation or not having the mutation leads to a difference in how long someone lives for. So that's whether they provide prognostic information. But at the moment, the jury's still out with a lot of these genes, particularly as our treatments are changing, whether they have prognostic information. Then what we hope in the future, as our treatment becomes more personalized to the patient, is that some of these mutations will give us what we call predictive information, that we can say, if you have a mutation in this gene, and this gene, then we know you're more likely to do better with this drug compared to if you have this combination, will you do better with this drug? And then potentially, as our treatments change, we may use these mutations for monitoring of your disease. So rather than just using the paraprotein, seeing whether it's going up or down, we might look for the mutations potentially in your blood or in other biopsies to see whether there's still low levels of the disease. But as I said, at this moment in time, really, it's mainly the MYD88 helps us make the diagnosis, but you'll often see if you read any of the clinical papers in outcomes with different treatments, we all look to see whether we can work out whether there's certain mutations that lead to better or less favorable outcomes with the newer drugs that we're researching. Yeah. So that's the diagnostic side of things. And once we've made the diagnosis, we'll want to stage the disease. And staging to me really means what's your burden of disease? We know you've got the disease, but really how much of the disease do you have? Because the next stage for me, once the diagnosis is made, is do I think the patient in front of me needs treatment? So there's different ways that we may stage or assess the burden of your disease. So like I said, the Waldenstroms can affect your bone marrow. So we might want to see how many of the cells we can see in your bone marrow are the abnormal cells compared to your normal blood cells. So that's the percentage of Waldenstrom cells in your bone marrow. We may look to assess the burden by just simply looking at your full blood count to see how much of the normal cells you're still producing. As I said, we may use a CT scan to get an assessment of the nodal burden of disease, so how enlarged your lymph nodes are, how enlarged your spleen is, and then also we'll do the blood test to check the level of the paraprotein. So these are all objective things we can do in the hospital, in the clinic, to assess how much of the disease you have. But of course, those don't tell us what you're experiencing as patients. So, for me, one of the key things in terms of deciding whether someone needs treatment or not is how you're experiencing, what symptoms you have, and how they're affecting your everyday life. So as I said, why assessing the burden of disease is so important is that once the diagnosis is made, then we need to decide, are we going to go, to begin with, down a route of active monitoring or watch and wait or active surveillance? Or are we going to say that actually we think we want to give you treatment to help improve your symptoms? Now, there are lots of international groups that have, international group, I should say, that have that come together regularly and meet and come up with guidelines to help inform some of these discussions. But really, in terms of indications for treatment, they haven't changed for over 20 years. So we haven't felt the need to update them. So there may be clinical indications, so the things that you're experiencing as a patient that may lead us to want to treat you. So some of them may be related to the effects of the paraproteins, such as the signs and symptoms associated with the very high paraprotein. So as I said, the nosebleeds, headaches, visual changes. If you've got a neuropathy, so pins and needles or numbness at its simplest, or potentially worse, neurological symptoms. or some of the rare complications that can occur with the paraprotein, then we'll want to treat, because if we treat the abnormal cells and reduce the level of abnormal cells, then we'll reduce the level of paraprotein and hopefully reduce the symptoms.
Good.
There may be that for some people, the lymphoma burden becomes very symptomatic so that they get bulky or symptomatic enlarged lymph nodes. We call that lymphadenopathy. Or enlarged organs, primarily the spleen. So we sometimes call that organomegaly. So the lymphoma burden may get too much, and that might be an indication for treatment. Yeah. And then the effects of the low blood count because of the marrow involvement, the bone marrow involvement. So I thought I would highlight a couple of recent publications just to give you an idea as a group what are the main reasons for treatment, the first treatment for patients. So one of the publications is from the Greek group who are interested in WM, and they looked at a large number of patients who had their first treatment. What were the reasons for their treatment? And you can see that the most common, you probably can't see the reasons at the bottom, but on the left-hand side, so 42% of patients, when they first needed treatment, they had low blood counts, in particular anemia, so the low red blood cells causing the tiredness, shortness of breath on exertion. So that was the main reason for treatment for just under half of the patients. The next reason would be symptoms, so the dramatic weight loss, night sweats. The next reason along was hyperviscosity, so the raised paraprotein causing that thicker blood. And then the next most common was the neuropathy, so the problems affecting the nerves related to the paraprotein. So they found that. And we have, within WM UK, published a couple of reports outlining data from the Rory Morrison registry. So this is UK data from UK patients. And again, showing similar kinds of things that actually at first treatment, the reason for treatment in just about 50% of patients were paraprotein related, and then 50% were lymphoma related. And so the paraprotein related reasons, the most common ones were neuropathy and hyperviscosity. And in terms of the lymphoma related ones, the most common reasons were fatigue and the enlarged lymph nodes, with fewer patients having treatment because of B symptoms. So when patients come to clinic, I think of this as a two-way conversation that you're trying to give us information to help us decide at the beginning, do you need treatment? And obviously from our side to give you information to help you feel supported, to understand that you know what we're looking for, and also to provide you the information about you and your disease and where we think things are heading. So when I see patients that have been diagnosed and are on active surveillance, what I'm assessing is, do you have symptoms and could they be related to the WM? If you've got symptoms, so if you come and say you've got tiredness, then what investigations am I going to do to try and work out whether it's related to the WM or something else? If I think your symptom is related to the WM, is this a reason to give treatment? Because I want to give you treatment if I think that's going to make you feel better. And then also I'm trying to get a judge of how quickly the symptoms are changing. So even if you don't need treatment at this moment in time, how soon should I see you again? How quickly do I think you will need treatment? And so you can see I love my tree diagrams. So this is another one here, but just to say that, you know, if someone says to me that they're tired, which is a very common symptom and obviously not unique to patients with WM, that what I'm looking for is that, is the tiredness because of anemia, so low red blood cells? Could it be that they're tired because the burden of disease of the WM is increasing? Or are people tired because they've got completely unrelated causes, in which case treating the WM isn't going to make any difference to their symptoms? So, you know, some people may have heart problems, other problems that may be causing their tiredness. So, you know, having tiredness doesn't necessarily mean it's related to the WM directly. So if we go down this tree, and it's obviously not complete, but if we use the example of if someone's tired and I see their hemoglobin is low, so those are the red blood cells are reduced, again, it may not be definitely because the WM cells are increasing in the bone marrow. So some people may have low iron as their cause of anemia. And so therefore, if I give iron supplements, if we give an iron infusion, that may help the hemoglobin and help the symptoms, and so we don't need to treat the WM. Similarly, there may be slight complications that can happen with the WM, that it's not just that the bone marrow problem where you're producing too many of the lymphoma cells, but some people may get a problem where they're breaking down the red blood cells too quickly, and we might try and give slightly different treatments in that scenario compared to treating because of too many abnormal lymphoma cells in the bone marrow. And of course, there may be other bone marrow problems affecting the production of red cells, although rarer to have two different pathologies and problems in the same person, not impossible. And so, for example, in the person with tiredness who's got a burden of disease or bone marrow infiltration by lymphoma causing anemia, that would be, for me, an indication to give them treatment of their WM to help their symptoms. Whereas, as I said, for someone with iron deficiency, which does occur more commonly in patients with WM because the WM affects the way that you absorb iron, then treating the iron deficiency may be all we need to help with that symptom at that time. And as I said, that some patients may get a breakdown of their red blood cells, and we might do things slightly differently for those patients in that scenario. And then the final thing really to say, and one of the aims of the clinic, isn't just looking at the WM directly, but also the indirect complications of WM. So a big thing for some patients isn't so much the lymphoma or the paraprotein, but the impact on the immune system. So some people, it's the recurrent infections are much more of a problem than the WM itself. So, I think WM UK help a lot in terms of giving the information necessary to patients and GPs regarding vaccinations. We can give advice on risk reduction of exposure to infections. And for some people need regular antibiotics to try and prevent infections. Or if you're not producing enough antibodies, in rare cases, we may, and particularly if patients have had lots of treatment, want to give other patients and other people's or donors antibodies on a regular basis to try and reduce the risk of infection. So that's so immunoglobulins, or sometimes called IVIG, so intravenous immunoglobulins that we can give to try and prevent infections. And this is very rare, but if you look at big population levels of big population of patients with WM versus a big population of people without WM, we know that the risk of other cancers is slightly higher in those with WM as with other lymphoid malignancies. Still unlikely to happen, but it's just good to have an awareness of it and be vigilant. So if you get skin lumps, moles, things that change, just have a lower threshold for having them investigated. And that is the end. So thank you very much for listening.
So we have a question that came in on Slido. So I've had 2 mid-88 tests, both came back as failed tests. Is this normal?
So it depends, not usually, but it is about the quality of the sample. So sometimes when you have the bone marrow, we take 2 different samples. You'll have the liquid sample and the biopsy sample. And sometimes the liquid doesn't pick up as many of the WM cells as the biopsy part. So if you've got very few there and you're trying to look for a mutation in those few cells, it sometimes can be hard to pick it up because it's what we call below our limit of sensitivity. But then, on the other hand, it can sometimes be harder for technical reasons to pick up good quality DNA from the biopsy part to get the mutation assessment. So it can happen. But hopefully with techniques that change with time, it becomes less frequent. And there are more sensitive ways of looking for mutations.
Is the level of paraprotein important in terms of deciding whether someone should have treatment as opposed to any symptoms they might have, or is the paraprotein level not relevant?
So that's a very good question. And just in case people didn't hear the first part, it's whether the level of the paraprotein is important or the symptoms and how they correlate. So I think that the short answer is that it's different for different patients. So there's no absolute number on the paraprotein level that we would say, oh my gosh, your paraprotein is 50 grams per liter or 60 or 70, and we have to treat now. That it's different for different patients. What we do find, though, is that it's kind of unique for you. So if you start getting symptoms when your paraprotein is, for example, 30 or 40, and you have treatment and the paraprotein goes down, that as we start to see the paraprotein coming up to round about the same level, or probably a bit before the second time around, we'll start to see those same symptoms come at that same level. So kind of it's worth remembering at what point you started getting symptoms, because it'll probably be the same for you as your journey goes on, kind of thing, and you need more treatment. But essentially it's the symptoms rather than the absolute paraprotein level.